Yeah, when you think about how genetics is used, I mentioned the early days when it was all research, and now we're pretty good at making the diagnosis. If we see someone with a problem, cancer or heart disease or you name it, and then finding the genetic cause. But for me, the big exciting part of this program, one of the big exciting parts, we want to be proactive about the genetics. We want to find a tendency to cancer before it happens.
Welcome to the Innovatively Speaking podcast, a podcast brought to you by the Medical University of South Carolina. On this show, we dive into the origins of the next big things, the who, the why, and the how. We explore ideas that are changing what's possible here at MUSC and in some cases all across the world. My name is Kevin Smith here in the MUSC podcast studio. With me, as always, is my co-host, the Chief Innovation Officer at MUSC, Dr. Jessie Goodwin.
Good morning, Kevin.
Good morning to you. Okay, Dr. Daniel Judge is our guest today, and we're going to be discussing genetics. Tell me a little bit about why this is such a fascinating topic.
Yeah, I think the field of precision medicine is becoming a bigger topic of conversation and more important in the way that we view how to treat patients. And Dan is the principal investigator on a large precision health initiative that is being run at MUSC called In Our DNA SC. And with the upcoming National DNA Day, he's the perfect guest to come and explain to the audience why we should care about genetics and where the field is going.
It's exciting. It's a big topic, so let's dive right in. Good morning, Dr. Judge. So a fascinating conversation on deck today. Set the stage a little bit by telling us how you got interested in genetics.
Oh, wow. So genetics is certainly a passion for me. I've been interested in it since my early training, and I remember asking the question why. Often enough, we often as healthcare providers will say, we don't know, and the technical term for that is idiopathic. If you really dig in on that, often there's a genetic tendency to conditions that we don't understand. What's changed over the last few years is that we can now dig in really well, inexpensively, and with more information that's available by DNA that helps us understand conditions.
It's amazing to me how far we've come, because it wasn't really that long ago that, we sequenced the first human genome, and that it was like the moonshot, right? And now we're down to looking for discrete changes in DNA that actually cause those conditions, like you said. And so you're a cardiologist, I believe, by training.
Yeah.
And so what was it within your own particular field that sort of drew you of down this path to really explore genetics?
Yeah, that might not seem like an obvious connection, but the person many people credit the field of genetic medicine to is Victor McCusick. He's passed away, but he was a cardiologist, and he was actually an identical twin, and he was fascinated by things that were running in families. So he was able to characterize genetic conditions in cardiovascular disease, and I had the opportunity to work with him very early in my career, and was really excited about the things that he was doing in that regard. And that was pre-DNA testing and early days of DNA testing when it was very research focused. What's been fun for me as a clinician is to be able to take some of that early research and apply it into practice.
Let's back up a step here. Jesse used the word precision medicine earlier. For lay people like myself, can you maybe unpack what that means in a little bit more detail? Yeah,
it's a term that's tossed around a lot, and let's talk more about what does it mean. And I think it can mean different things in different contexts. I think being precise about a diagnosis is important, not saying you have a heart problem, but to say, here's the exact cause of that problem, or cancer. We know cancer happens for lots of reasons, and there's lots of environmental factors that contribute, but there's genetic factors too. So the precision part comes down to not just figuring out a gene or a portion of your DNA that's responsible, but right down to the very individual change in that DNA.
By knowing that sort of discrete change in the DNA, are you able then to sort of select the treatments with better, I don't want to say accuracy, but with that individual in mind?
Yeah, thanks, because that's, when I say precision medicine, it's not just the diagnosis, it's the treatment side. And so let me take that a few different steps. One is the specific treatment. In some cases, we do have specific treatments for specific DNA changes. In other cases, and this is something great about the program we're doing, we're able to find the right medicine based on your genetic tendency to metabolize. We know some medicines are just not the right combination for you with your DNA, and now we're able to use that information.
Yeah, I have a personal connection to that. So my husband actually has what's called acetylcholinesterase deficiency, which is a mouthful, but what it really means is that he doesn't process certain types of anesthetic appropriately. And the way that they actually found it was that his cousin had surgery and woke up paralyzed because they didn't know that she had the genetic disorder, and when they gave her that type of anesthesia, her body couldn't metabolize it, and so you wake up, but you can't actually move, and it's terrifying for them. And so for us, sometimes it's not even about like what type of medicine should you get, but also what kind should you avoid, right? And so now we know that, and we test our children, just because knowing is power sometime, right? So
knowledge is power, absolutely.
It is.
And speaking of that, I jotted down a quote from you, Dr. Judge. We're doing this to be proactive about health, the idea that knowledge is power. You can use these results to prevent the problem that's being investigated. That's that prevention side of healthcare is huge, and this is what this is all kind of pointing towards, right?
Yeah, when you think about how genetics is used, I mentioned the early days when it was all research, and now we're pretty good at making the diagnosis. If we see someone with a problem, cancer or heart disease or you name it, and then finding the genetic cause. But for me, the big exciting part of this program, one of the big exciting parts, is that we want to be proactive about the genetics. We want to find a tendency to cancer before it happens. I think one of the stories that I like to point to, and I don't know anything very specifically about Chadwick Boseman, a famous actor from South Carolina. People probably know that. And he, in very public information, had metastatic colon cancer in his 30s. I don't know if it was genetic, but it has that sound to me. And in the setting of a genetic tendency to cancer, we start screening early. We don't normally do colonoscopies in 30-year-olds to look for polyps, but with a genetic tendency to cancer, we can do that. We can start early, and we can find those polyps before they become cancer.
And actually, that is one of the disorders that we look for.
Yes, it is.
In our DNASC, a family of disorders called Lynch syndrome.
Yeah.
So can you talk a little bit about what the NRDNASC initiative is that you're leading?
So it's a community health screening program, and I think that's the first way I think about it. We have several different areas that we're working on in the long run, but the front piece of this program is the screening of three conditions that the CDC says these are proactive conditions. You can find a tendency before the problem happens and do something about it. So colon cancer, you talked about that. Lynch syndrome is the technical term for that, but a genetic tendency to colon cancer. If cancer's run in your family, it may be one of these 5 genes. Breast cancer, now there's a lot of causes for breast cancer, but the top 2 genes are BRCA1 and 2. Sometimes people call them BRCA1 and 2. And we look at those genes as well. And then 4 genes for high cholesterol. Hypercholesterolemia is the technical term. If you have a major change in any one of those genes in those 3 conditions, we tell you about it from the beginning. That's the first part of the study results. Around 1 in 75 people has a major change in one of those genes, and we can do something about it.
Yeah, I think it's pretty amazing. Angelina Jolie, I think, made the BRCA1 and 2.
Yeah.
Pretty famous when she was diagnosed after a history, like within her family, and then decided to take some preventative measures. But at least it brought it to the forefront of people's knowledge that you can look for this and sort of avoid long-term.
Well, and she did what is not required, right?
Correct.
She had mastectomy and oophorectomy. Again, this is very public information. And that's not the only approach. Sometimes just early mammograms or breast MRIs or other screening techniques can find cancer at its very early stages or find things that are precancerous. And so I think that's one option, meaning Angelina Jolie's approach, but there's other options too.
Well, let's talk to somebody who's listening right now, a younger person who maybe is like, I think there's some tendency for people to think, I don't know if I want to know.
Yeah.
So maybe talk to that, but also maybe walk me through what this person would do to get on board with what you're doing and to find this information out, and then reassure them that when they do find this information, that's actually a good thing and that moves towards a solution.
Yeah, I think I have a few thoughts along those lines. First and foremost, if you find a genetic tendency, it doesn't mean the cancer is going to happen or the heart disease is going to happen.
Yeah.
In fact, these are the 3 conditions we think are proactive, that you can do something about it if you find out early. So back to that idea of knowledge is power. The other part of it is, I think, that sense of I don't want to know. It's a common one. It's not for everybody. Some people just don't want to know, and that's okay. We won't force anybody to do this, but we do think it's a good idea for people who have cancer or heart disease in their family to sign up and find out, do they carry something that we can track and look for. So I hope it's something that people will listen to and hear and say, I won't be worried about this. I'll be proactive about it.
Well, what's the process of getting in the pipeline?
Yep. It's easy. You sign up online. And I know that might not sound easy to everybody, but if you have a MUSC MyChart account, in there you'll see under the research tab a study that you can sign up for called In Our DNA SC. The other is to go through our website, which is inourdnasc.org. So that's not .com, but .org. From there, that takes you directly to your MyChart. Sign in through there. Read a long consent form. Because there's research involved, you have to go through a lot of pages of understanding exactly what we're doing with the DNA and the information that you provide. After that, once you've signed up and taken a short test, it's a few questions that say, did you actually read the stuff we asked you to read? From there, once you've signed up, you have two choices to provide a saliva sample, a DNA sample, either through one of the places where we're collecting them or by mail. If you live far away and you don't want to drive into the city, just click that box and we'll send you a kit in the mail. And that's something you can just follow the directions, provide saliva in that kit, and mail it off. It's all done for free, including the mailing.
And you actually get, and I've done this.
Yes, good.
I am a participant. And you get two sets of results, which are both pretty fascinating. The first set that actually came in, it actually preceded the genetic results for those genetic mutations that they're looking for. But the first set was actually pretty fun to read and to look at with my kids. And, it told whether or not I was genetically predisposed to things like having freckles, which I am. But also like whether or not I was built for endurance versus speed.
Yep.
It's endurance, by the way.
Yep.
So you kind of get that same sort of fun genetic info in addition to just the clinical information as well. So both sets were kind of fun to read and then review with my children as well. They kind of sort of start to give you a whole picture of who you are as an individual and how your genes played a role in that. So
it's really a tendency too. That's one of the areas where we've had the biggest list of pushback and saying, hey, I really do like caffeine, or I don't have curly hair. And so those are just tendencies. Those aren't exact. So remember in that first part, if you get something back that says, hey, you may have freckles or you're predisposed to freckles, but you don't have a lot of freckles, that's still okay. It's just down to the odds, but it's not an automatic, like a lot of genetics.
Yeah, it's never a 100%. It's
Correct.
Just whether or not you have a tendency towards it or not.
It also provides ancestry information, right?
Yes.
We've had people who signed up saying I was adopted and I wanted to find out more about where I came from. And that information's available. And again, it's one of those things that's not part of your medical record, but it's interesting.
And all right, we'll talk about the medical record part. When that comes in, what if there's something scary in there?
Yeah.
Talk to the person who just opened the envelope.
Absolutely. And that's an important part where we've really made sure that we provide the support that we think is required. So if you have one of those three conditions, the top conditions that we're looking for at the first part of the study, we will provide a genetic counseling visit that's usually done by phone or video or in some way that's easy for you to talk through what do these results mean and what are the next steps, because that's the important part. We don't leave you on your own, and we're not going to push it back to your primary care physician that might say, I don't know what to do. We'll help you connect, and again, that's all done for free. That will walk through what are the results not only for you, but what are the implications for your family, and how can they take next steps to be proactive about whether they carry the same tendency. So that's just on the positive side. On the negative side, you just get a message that said the three conditions, the 11 genes look good.
You mentioned that this is also a research study, and I think I mentioned that you were the principal investigator with the word investigate in there. So what is the research piece of the NRDNASC?
Yeah, there's a lot of pieces, and thanks for asking, because I think at the top of my list, when you think about what's normal DNA, we have reasons to think certain DNA sequences are more common or normal, and that's based on these registries of people who, like this study, have provided a sample and it's cataloged. It's available online, and no one's name is tied into those. And that may be someone from London or Boston or California, and that's not South Carolina or the Southeast U.S. So having good representation for what's normal, what's common, what's rare in this part of the country is important for us to know what are those changes when we see them. Second on the list is understanding diseases better. So I talked about 3 conditions that are top tier for CDC and for our program for screening, but there's a lot of other things that we're interested in. What are the genetic factors involved with high blood pressure or liver disease or other conditions that we might be investigating here at MUSC or in conjunction with our colleagues at Helix, a company that's working on this with us.
Yeah, and it takes large data sets in order to be able to explore those things and to arm, a community of researchers with enough data to be able to really look in and start to understand what are those genetic changes that may be sort of an underlying cause of certain conditions. That way we can then sort of do the next step of targeting better treatments for them. And that was what appealed to me about participating, was just being part of the larger sort of population health sort of movement and knowing that my small contribution could impact in an aggregated way something really sort of impactful and beautiful in my mind.
And I think that gets back to, well, who might be interested? And we want everybody who's interested. And so if you're healthy, we're interested. If you have a condition that no one understands, please sign up, because that's where we can try to figure it out. We'll have your DNA. And we're looking at, we didn't talk about this already, but we're looking at all of your genes. So that's 20,000 genes and some other portions of the DNA that help us understand why diseases happen. So I think there's a lot of information we'll be able to have. And if you're alone or feel like you're alone with a rare condition, there may be others at MUSC that have that same condition and hopefully who are participating, and we can compare those DNA sequences.
Yeah.
Bring together a community
Absolutely.
Of people who struggle.
Yeah, I was going to say, and you just alluded to it, but I think it is important to reinforce that it does take a full community, right? And so the goal is to get a really broad set of people. We need sort of a diverse array of ages and genders and races in order to actually be able to really look at these things.
Yeah, it's such an important part of this study. So we don't want this study to be just, what's happening in Charleston. We want it to represent the state of South Carolina. So that's people who are here with different ethnicity, different background, different medical conditions. And whether you're urban or in the cities, wherever if you grew up here, if your family's been here for many generations, or if you moved in here from someplace else, that's what we're interested in understanding, and that's part of the program, is to have good representation of everybody in the study.
We talked a little bit about how to participate, but what is the actual act? Can you describe what's expected and how they actually donate DNA samples?
Yeah, so I think that's a question a lot of people have, is what happens to my DNA afterwards? And is someone sharing it? Where's it going?
Right, privacy concerns and all that.
Absolutely. And so it's such an important part of this, and I'm glad to talk through that in detail and hopefully dispel some rumors or myths about it. First and foremost, it does get into your medical record. So we had the early discussion, if someone says, here's my DNA, but I don't want it back in my medical records, we don't want you to participate. We want this to improve your health care. So that's the whole goal.
So I imagine that a question that you get often is concerns about what happens with their health insurance or their life insurance if they find out that they have one of these CDC Tier 1 genetic mutations. Do you have a response? Can you share what you tell people?
Absolutely, and thanks again for asking. So first and foremost, it's law, the Genetic Information Non-Discrimination Act, that you can't use genetic information on health insurance or employment information. However, there are things like life insurance or long-term care insurance that are subject to DNA results being there. When you have a life insurance policy, a new condition or a new genetic piece of information will not affect your policy. Your policy stands. And remember, life insurance, they're in the business of predicting when you're going to die, and so they're going to take all information into account. They'll take your zip code, they'll take your income, they'll take your gender, your age, your everything into account. And one of those things is, well, your genetic information. If you have a genetic tendency to cancer or heart disease, they'll use that. So I think if people are thinking about going out and buying a life insurance policy other than what they might get through employment, do it beforehand. That's a good idea. If you already have your policy, don't be dissuaded, because that policy will remain intact, and then finding the genetic tendency should help in the long run in terms of preventing the condition.
Just thinking, I mentioned that I had participated in the study and am a proponent of just doing this from a population health standpoint, but I actually chose to participate in this very specifically after a conversation with my gynecologist because I'm at an age and I have a strong family history of colon cancer. So I am someone who had to start getting colonoscopies in my 20s because my parents both had polyps in their early 50s and they sort of roll back 20 years. And so you're kind of like, well, colon cancer and gynecology. But they were worried about Lynch. And what I didn't know was if you are someone with Lynch syndrome, right, you have to worry about other organs as well. And so it ended up being a way to get some genetic info that was needed to help me make some other decisions for my own personal path of care based on my age and just other things in life that I needed to consider, and so to be able to inform my 3 daughters as well. And so actually participating in the InterDNASC was a way to actually sort of fulfill both of those things, to participate in a large initiative and also arm my physician with some information that she needed in order to help guide my own care. And then fortunately for me, I was actually negative for Lynch. And so while I do have a strong family history of colon cancer, it's not due to one of those genetic mutations that we have to worry about. So that was actually really helpful information. So now I know, continue with my colon cancer screening the way that we have been, but it allowed us to make some other decisions in terms of my own personal care for other things that, was all based on the results of this test and a negative but positive outcome for me, if
great.
you will. Yeah. So
knowledge is power, for
real.
Yes.
It is. And so, for someone like myself or my family is where you are sort of working through, you have a strong family history, it can help, outside of just, I already knew I had a strong family history for colon cancer, but it helped guide other decisions as well.
It can become even more powerful if someone in your family has the condition, and then we find the genetic factor and we can say specifically like yes or no on that. So we're a screening study, and so we're good in that sense, and it's so good to hear that the results were negative for you. But if there's a family member with early cancer and we can say there's the cause, we can really check yes or no for you more definitively.
Can you give us any anecdotes about some interactions you've had with some participants in the study who maybe have reached out to you and needed some guidance?
One person I mentioned was adopted and had no idea what their background was in terms of ethnicity or family history. And so we've had a few people reach out in that regard of saying, this was really great for me to understand a little more about where I came from. For people who have a positive result, in some cases it's helped them understand why they had early cancer. In some other cases it's an easy answer for why their cholesterol is high. It's not their diet, or some of it's their diet, but it's not all their diet. And for a lot of people, it also provides that family connection. I think it's taking those next steps. It's not, sometimes it's really obvious based on your family history that there's something going on, and then being empowered to say, well, so my children will have this gene, or they won't have that gene, or to test family members who are at risk.
Well, point us towards the future a little bit. What are your hopes for the findings that you may, come out of this research? It seems like the possibilities are massive.
Yeah, and as a clinician, the number one thing on my list is to make health better, and that gets back to find the condition, find the tendency to healthcare problems before they happen, and be proactive about it. Don't get caught by surprise. So that's at the top of my list in terms of hopes, and we're already doing that. So I'm glad about that, but we can do more of it. Second on my list is the research. I think on the research side of things, understanding disease better, being able to figure out why certain rare conditions or common conditions happen because of the genetic research. And third, we didn't really talk about this too much. We talked about it a little bit, about the ability to target specific medicines, back to the precision medicine. We're automating that so that your doctor doesn't have to think about that when you have this, when you're part of this study. Your genetic information goes into your healthcare record at MUSC, and if a doctor puts in a prescription, an acetylcholinesterase, you mentioned that example, and you have that deficiency, or it might be something as simple as codeine, a common medicine in cough syrup. Roughly 5% of people don't respond to it at all. They could take it and not ever have much of an effect. Another 5% have a super response. So just a little bit goes a long way, and we can figure that out in advance and say, don't use that medicine, choose an alternative. So those are some of the examples of where I want to see this study continue to grow.
It's exciting.
I think it really is exciting. That sort of leads into that field of, with the fancy name, pharmacogenetics, right? And so can you tailor the drug choices that you're giving to people based on how they're going to respond to them, so that it's less of a trial and error, but really sort of tailored to that specific individual and their own specific way of processing things, which I think is really fantastic.
Yeah, there's lots of medicines for anxiety or depression that really have strong factors that we know and we can use. There's a common medicine that we use for people who have a stent. I'm a cardiologist, and if you get a stent in one of your arteries, we use a medicine called clopidogrel or Plavix. if that medicine is prescribed for you and you have a genetic tendency to not metabolize it, it may not work very well for you. And we don't have time when we're putting the stent in to get that result back, but if you have your DNA sequenced in the beginning, we'll have that information available for you later.
I mean, shortening the time from, knowing what the issue is and how to get the help. I mean, that's what it's all about. This is fascinating. It just seems like almost like a shortcut.
Yeah, well, it's something interesting, because I think this gets back to why was the study started. It wasn't my idea. I'd love to take credit for it, but I can't. It comes from the highest levels of MUSC, and I think we want to see genetics be part of healthcare, and that's where we want to lead the way at MUSC.
You've been listening to the Innovatively Speaking podcast with the Medical University of South Carolina. If you enjoyed this episode and would like to support the show, leave a rating and review. To hear more innovative ideas and to share your own, subscribe to the show or visit us on our webpage, web.musc.edu/innovation. And remember, don't hesitate to innovate.